think morning we started with the refractive subspeciality, and we could able to cover the imaging and the machine. But now we'll continue with the complex case management, also with the modalities of treatment. Have with us Lieutenant Colonel Sagarika Patel. I welcome you, madam. She is the convener of this session, and I am Dr. Krishna Prasad Kodlu moderating this session. To start with, we'll have surface ablation by tips and tricks to perfect PRK. Dr. Anuj Sudhija. Dr. Anuj?
So how much time are we giving each speaker? This is what he's asking.
No, 6 minutes. इधर लिखा है ना, इसमें लिखा है, एक कॉपी में लिखा है.
5 minutes. Okay.
No, 6 minutes. Some people 6 minutes, some people 3 minutes. You have to see the.
Okay, sir. Okay, right.
We are written.
And are we marking it?
No, not
Nothing.
marking.
Just here. That's
Yeah,
all. Nothing.
It is not marking. Madam.
Achha, it is just a
Yeah.
open session.
Open session.
Okay, theek. What's your name? My name is. I'll just write it down for you.
So,
Ye beta ye kaja.
I request
General.
Dr. Ambrish Darak is also the co-convener for this session to join the dais. Second, LASIK complication and management. Bhavya, do you have Dr. Bhavya? I think you can start.
Krishna Prasad Kundu.
Your time is for 6 minutes, so try to cover. Already we are 1 minute delay.
No question answers. Nothing. Just.
A very good afternoon to everyone. So I'll be discussing the complications of both intraoperative and postoperative complications of LASIK and their management. Obviously, I won't be able to cover all the complications in 6 minutes talk, but I would like to include as many significant ones as possible. So when we talk about complications, it's actually convenient to divide them into intraoperative, postoperative, and intraoperative, since we have two different techniques of flap management, the microkeratome and the femtosecond laser. So the complications, the way they occur, how to handle them, all is I won't say completely different, but it is majorly different between the two techniques. So I'll be discussing the complications under these heads. So let's come to talk about microkeratome flap complications. Even though femtosecond laser is much advanced in flap making and management, most of us are still using microkeratome. And the research says that the prevalence studies, microkeratome flap complications are one of the most common complications of LASIK even nowadays. So I'm not including again all the flap complications. I'll be including the ones which are most visually significant. So the first complication I'd like to talk about is free flap. So what is free flap? A flap that lacks a hinge. And what are the consequences of free flap? Why do we have to worry about free flap? Because one, most obvious, there's a risk of loss of flap and presence of irregular astigmatism when we replace that flap, and a risk of epithelial ingrowth if that is improperly positioned. So the first thing, when I talk about management, as always, prevention is better than management. So how do you avoid free flap? The most important part of the flap management is obviously the suction. So ensure sufficient suction of the microkeratome over the eye. So I'm a beginning surgeon, I'm learning. So how do you check that suction is appropriate? The indications are you have to ensure sufficient intraocular pressure, palpate the cornea for firmness, ensure that suction ring has a firm grasp over the eye. So if you're not sure, it's better to make sure that the suction is enough rather than just proceeding prematurely. So once, yes, the free flap has happened. So what do you do? How do you do? So some of us actually prepare for it beforehand. So there is this process of asymmetric markings. So if you are a beginner surgeon, if you're not sure about your technique, if you are in the process of learning curve, it's always good to have an asymmetric marking. So the marking will help you. So what is the importance of repositioning the flap accurately? It's not just replacing the flap. It's also important that you have to replace the flap as accurately, as anatomically accurately as possible. As I said before, the risk of irregular astigmatism is going to be visually significant. So if you have asymmetric markings, they're going to help you a lot in replacing. If you don't have, in the event that you don't have an asymmetric marking pre-operatively, so there is this hypothesis, there is this theory that the flap, even with the best of the microkeratome, is thinner in the beginning and the end of the flap making, and it is thicker in the center. So it acts as a plus flap cylinder, and the stromal bed obviously is a mirror image of the flap. So by measuring the post-operative manifest refractive error, particularly the cylindrical error, that can help you in repositioning the flap again. So the patient, so in here, you just reposition the flap intraoperatively, and then based on the postoperative manifest refractive error, you go back, take the patient back to the OR, and rotate the flap based on the astigmatism. But the limitation of this technique is, in this we are assuming that the laser, the ablation itself is not inducing any astigmatism, and it is not, so you have to take into account the preoperative astigmatism and then do these calculations. The next important is complication is irregular flaps and flap buttonhole. So we know these are ring-shaped flaps with a central hole or thin area. Again, the incidence of flap buttonholes is higher in microkeratome made flaps than femtosecond. So here again, there is machine-related and there is the patient anatomical related factors. So machine-related factors, as I'm going to talk about this again, is loss of suction during the transverse cut, or inadequate suction. So inadequate suction or very high suction, like in case of central corneal buckling. So also the poor ocular surface. You may have good suction, but poor lubrication of the corneal surface or keratome malfunction. So anything that is happening at the suction level can cause a flap buttonhole. So why do you have to worry about it? Again, it causes very high visual disturbances because most of the cases the buttonholes are in the center. So they're going to be very visually significant. And it's not just the higher order aberrations. The patient will suffer with loss of BCVA as well. So it is a very serious consequence, refractive surgery complication. So how do you avoid? Again, carefully set up, review your microkeratome, the laser, and do not, and the most important part of flap buttonhole. In the previous complication, we can go ahead with the ablation. But here, be cautious, do not ablate a poor quality bed. Do not ablate in case of a flap buttonhole. So in here, it's better to wait, let the buttonhole heal, and then you can go for a deeper flap at a later time. So next important one is flap striae and folds. So here I'm trying to show you how to differentiate microstriae and macrostriae. This differentiation is important because microstriae are usually visually insignificant. When I say visually insignificant, I'm talking about the BCVA, but they may have other visual aberrations like halos, but microstriae are the ones which are going to reduce the patient's BCVA, UDVA. So the differentiation is that macrostriae involves the stroma, and clinically, based on the fluorescein pooling, you can differentiate them. So again, as many other flap complications. Okay. So femtosecond laser, loss of suction is the most important one. Again, here, the patient-related factors are also there.
Just wind up.
Yes, sir. So I just want to briefly talk about interface complications. Here I'm showing you the different types of interface complications. The most important thing is to differentiate infectious versus non-infectious complications. That's where our management depends. And again, the one identity that stands out is pressure-induced stromal keratopathy, because here we don't give steroids, we stop steroids instead of giving them. And always rule out infectious etiology when you are going ahead and stepping up your steroids. And then one of the laser-related ablation-related complications is decentered ablation. The most important part is diagnosing that the patient.
Please wind up. Your already time is up. Okay. It's a 6 minutes talk. You need to find out what you have to talk within 6 minutes.
Sure.
You can talk for 60 minutes. You can talk for 4 minutes. But time is very, very important.
It's okay. I can move on to my next talk, sir.
Yeah. Which is your next talk?
Planning the retreatment.
You come afterwards. Now,
Sure.
once again with the PRK, let us go in the stepwise. I think Dr. Pooja, she'll be talking about the surface ablation. I welcome Dr. Gaurav Luthra, who is chairing this session. He's a prolific refractive surgeon from Dehradun. Welcome, Gaurav.
Thanks, Dr. Kudlu. Thank you so much. Very good afternoon, everyone.
Why is this not coming?
Do you have Dr. Prasanna Thakur? Same talk.
A very good afternoon to all. I would like to thank Dr. Kudlu sir, Sonu Goyal sir, and the entire AIOC team for having us a part of this session. So I'm just going to give a very quick and a short talk on tips and tricks for a perfect PRK. So we do know that PRK have a lot of advantages which we don't need to go right now. But it did go out of walk because of two reasons, which is one is the severe pain and second is the corneal haze. Now let's look into the first issue, severe pain. It is because of the exposure of nerve endings, enhanced spontaneous activity of injured nerves, and release of prostaglandins and neuropeptides. We do have BCLs, but we do not have any active mechanism. Topical treatment can lead to surface toxicity, and oral can lead to systemic side effects and limited maximum daily usage. So can we make a topical pharmacotherapy safer for PRK management? What did our group do was we devised a technique which is ketorolac soaked BCL, where we took the BCL packet, soaked and injected the ketorolac solution 0.5% into this packet, preservative-free, suspension-free, and waited for 20 minutes. And after 20 minutes, as soon as the surgery was over, it was placed on patient's eye. So post-operative, what we saw was that if we used the conventional BCL, the scores were around 8 to 10 on average. But if we use a ketorolac soaked BCL, the pain on the Wong-Baker pain scale came down to 2, which is quite a good thing for PRK. And a lot of times they come second day, they come with a crystal clear eye as if they had got a LASIK done. So the second one is corneal haze. This is how the normal healing happens. Whenever you do a PRK, there is activation of keratocytes, and then there is formation of fibroblasts, and then they apoptotize to get a normal cornea. But in inflammatory condition, there is excessive formation of this myofibroblast and fibroblast, which leads to aberrant collagen, which leads to formation of haze. So now how do we do it? What do we do? Our group found that if there is a preoperative inflammation present, then post-operatively, these patients are at a higher risk of haze in spite of when you have used mitomycin C or if it's a lesser depth ablation. So we devised this perfect protocol where what we do is we devised a risk scoring system. Preoperatively, if there is a higher inflammation, which you can take with OSDI scoring, or if the patients have low vitamin D, or then if the patient has low vitamin D, then also they are at higher risk of developing haze post-surgery. So to look at vitamin D is extremely important. If the patient have history of contact lens intolerance, that means it's an unhealthy ocular surface, that means it's inflammation, and you would like to treat the patient before taking them up for surgery to reduce the haze for them post-surgery. Meibomian gland dysfunction is also a sign of inflammation, so you need to treat them before taking them up for surgery. And post-surgery, you need to ask them about the working environment, because if they're working outdoors, they are at higher risk of developing late-onset corneal haze, and you have to instruct them about the working condition, and they have to use UV protective sunglasses to prevent haze. So if we divide the risk scoring system in less than 5, 5 to 10, more than 10. If it's less than 5, you can take the patient up for surgery. But if it's moderate to high risk, before surgery, treat them with a short course of steroid, cyclosporin, and treat the vitamin D, and then take the patient up for surgery. Intraoperatively, look at the epithelial tightness. If you're removing it with manually, if it's loose, that means it's inflammation. If it's intraoperative excessive secretion, that means it's a sign of inflammation, and post-surgery, you need to keep them on higher steroids. And ketorolac soaked BCLs do take care of the inflammation, so we are at ease that, that will take care of some amount of inflammation and optimizes the wound healing. Low risk, you can go ahead with your normal treatment regimen post-surgery. But if the patient had a high-risk score to begin with, post-surgery, the first choice of steroid would be a prednisolone for 4 weeks, followed by loteprednol for 8 weeks in a tapering dose with sodium hyaluronate, cyclosporin for 6 months, and treat the nutrition according to the WHO guidelines. And if it's if the epithelium was extremely loose and the secretions were higher, please add a tablet doxycycline for 15 days for this patient. So we can predict, examine, treat, follow up the patients for having a perfect PRK for these patients. Thank you.
Thank you, Dr. Pooja. I think the discussion, Chairman, any comments from Gaurav?
I think very nicely summed up everything, and I'm personally using ketorolac as well, and it's shown dramatic results, and our patients for PRK are so much more comfortable, plus all the other things that you spoke about. I think ma'am had a question whether cyclosporin will actually work if used for, when used for just 4 weeks prior to.
Yes, ma'am, cyclosporin can be used because the dosage what we are using, 0.05, it's actually an anti-inflammatory dose. It's not an immunomodulator. And the substance they come with doesn't have any side effects. So we can use for 4 weeks before surgery. We do it with steroids, and it does bring down the levels of MMP9.
Have you tried that, whether you have separated the steroids and the cyclosporin and just see that one, because you're putting so many drugs?
We have done both, and what we feel was that a combination of steroid and cyclosporin works better.
Was that an objective study?
Yes. Thank you.
Quick question, sir. The ketorolac soaked BCL that you've been using, there are some papers which have published which say they have corneal melts or even problems which are extremely bad if you have one. Do you have any experience with that? I think.
So nepafenec is the one which has been more reported for corneal melts. Ketorolac has been found to be relatively safe, and I don't know if there are any reported instances of corneal melts with ketorolac soaked BCL.
So you use them for all your
I've been,
PRKs?
yes, all my, not only PRKs, even my CXLs I use for all my CXLs as well, and I've been doing them for about 3-4 years now, and we don't have problem yet. But see, it's a new thing, and it's always open to scrutiny. Yeah.
No, streamlined PRKs also you would do.
Yes. Yes.
Thank you so much.
What we have observed is if it's with preservative or suspension, then there are chances of corneal
Yes.
melts. But what we are using is suspension-free and preservative-free.
Yeah, absolutely. So Accusade is.
Ma'am, at this point of time, the only company which is making it is from Entod, which is the Accusade.
Accusade.
Yeah.
Yeah.
Unims, they have unims
Yeah,
which are
unims.
preservative
Unims
free.
preservative free.
Yes.
Thank
I
you
think
so
we should
much.
go on.
And let us go to the next talk by Dr. Bhavya. I think she'll be talking about 5 planning a recorrection. Over to you, Bhavya.
Okay. Thank you, AIOC, for this opportunity. So I'll be talking about planning the procedure of retreatment. So the first determinant you have to think about before planning retreatment is to ensure minimum corneal thickness of more than 450 microns. So any planning of retreatment post LASIK, you can proceed only after this checkpoint. So once you make sure that the corneal thickness is more than 450 microns, but I would like to caution the audience that measurement of corneal thickness is little more unpredictable in post LASIK eyes compared to virgin eyes. Once you make sure that the corneal thickness is more than 150, the next most important determinant in planning a procedure is duration of interval following LASIK. So we know that flap lift of more than 10 or more years after LASIK, the ease of flap lift is different in shorter duration flaps compared to longer duration flaps. There's a difficulty in flap lift and there can be inadvertent flap tears when we attempt flap lift in a longer duration flaps. In less than 10 years duration flaps, look at the epithelial mapping, whether it is an irregular epithelium or a regular epithelium. So in case of a irregular epithelium, in a thicker flap with a minor refractive error. So all these stepwise determinants help you. Basically, when you look at refractive error, you are looking at the maximum ablation thickness, and also in combination with the flap thickness. So if in a thicker flap with a with a lower ablation depth, you can go ahead with the surface ablation procedure. In a similar scenario, but if the flap is thinner and if your ablation thickness is higher, so it's basically the combination of the flap thickness and the ablation depth. So if that is not going on with each other, then you'll have to go for a flap lift and stromal ablation. In longer duration flaps, you have to look at the flap architecture and the thickness. So it's basically comes down to the flap regularity and the thickness. In regular and thick flaps, you can either do surface ablation or flap lift, as I told you again, based on the ablation thickness. But in case of a regular and thin flaps, if the ablation thickness is less than 40 microns, so you can go ahead with surface ablation. If it's for higher refractive errors, you'll have to do a recut. Since this is a thinner flap, rather than reattempting flap lift, it is better to do a recut. In case of irregular flaps, we don't have any other option rather than recut. In case of higher refractive errors, again. So it drills down again to the ablation depth and the regularity of the flap. So these are the techniques of the flap recut. So during retreatment, so the final algorithm is this. So here, if you look at all the determinants are the duration of the flap, the ablation depth, the flap regularity, and then the regularity of the surface. So based on the ablation depth and whether we first choose whether we need to do a flap lift or we can do a surface ablation. In cases of low ablation depth, it's always better to do a surface ablation. And in case of irregular flaps, beware before attempting a flap relift. And if there are low ablation depths, do a surface ablation. If there are higher ablation depths, you have to go for a recut. While doing recut, look at the flap thickness, the resident flap thickness, the flap architecture, and then proceed planning for a flap recut. Thank you.
There are many people in the audience who are doing LASIK and PRK and redos quite frequently. So my only question to those people, can anybody has quick comment on what will be the simplest process to do a redo? Because whatever presentation says, in our private setup, we don't have these kind of equipments and everything with us. So what is a practical solution? Can someone come up with that? Yeah.
I think surface ablation is the ideal option, if you ask me. But as we all know, if you tend to go for the higher ablations, it is going to create haze. So up to -3, -4, I think I would like to go for the surface ablation.
So I think with that we'll go on. Another thing is the use of the BCL. Whenever you do a flap lift, it's absolutely, I mean, that's a must. Otherwise.
Sir, can you use the Ketorolac soap BCM for those cases as well?
Yes.
Yeah, I haven't used it, so. Pooja, yeah?
We use it for all our spine extra patients.
Is that right? Great. So I think we'll go on, and we have a very interesting session coming up, a rapid fire round after this. And this is first, we have Dr. Kudlu himself, member of the scientific committee of AIOS and prolific speaker. He will be talking to us on smile complications, avoiding and management.
Thank you, Dr. Gaurav, for the lovely introduction. I think this is my financial disclosure. It's not coming. Yeah, common complications of smile. I think I'll be talking about only 4 complications. Major complication. One is suction loss. Second one is black spots on the cornea, folded lenticule, and lenticule on the flap. So suction loss is the most common complication in smile. I think if you won't keep the conjunctiva dry, this can happen, or even in some anxious patient. So yes, before doing the side cut, only suction loss has been happened. Suction loss during the lenticle cut, you can convert into femtolasic. If the suction loss during the all other stage, side cut, cap cut, incision, you can do the recentration after the suction. Then you can clear the bubbles from the center of the cornea, wipe the undersurface of the contact lens, then go ahead with the treatment. It will do the treatment in the same plane only. So how to avoid it? Make the patient comfortable. Some of us, I think, giving the patient alprazolam might help also. Give a detailed instruction before the procedure, do and don'ts by the doctor only. Choose the right size cone is very important. White to white less than 12 mm, go for small size cone. White to white more than 12 mm, always go for a medium size cone. The last very important thing is keep the fornices dry and the cornea moist during the treatment. This is the take home message. This is the second complication, that is a black spot in the cornea. See, this happens, I think happened to us because many a times a lot of training students tend to come to us without making the cornea too dry also it can happen. So you can see a lot of non-treated areas, especially in the superior part near the incision, that is make the surgeon heck of a scene during the surgery. So how to avoid it? Once again, keep the fornix dry and cornea moist, very very important. And always prevent or remove all the debris getting collected under the treatment cone. But very important thing is do not applanate the cone over the cornea more than 80 to 90%. If you apply it up to 100%, suddenly it may cause a corneal folds and it can end up with a lot of dark objects. This is one more complication I'm just showing you. The folded lenticule. See the treatment done perfectly by the machine with the first lenticule cut, side cut and the cap cut and the incision. So identification of the layer also done very well by the doctor. Then what was happened, see, while dissecting the posterior layer, he went with the only one side first without realizing. See, always you have to leave behind a small knuckle on the one side, then only you can dissect it well. Now you can see a lenticule has been folded so much. In this very simple, go with the forceps, try to hold the lenticule, try to do something called a reverse rhexis towards the 6 o'clock and you can easily remove the lenticule. So you have to keep your mind cool, don't try to pull that time you may have a lenticle tone. So you have to be very very careful while doing this procedure. Once if you do that, then it's quite easy. This is one more complication, that is a lenticule on the flap. See here once again identification of the layer done very well. But surgeon might have been really took his eyes off when he is entering one more time with the long dissector. So he has gone inside. See, whenever you are doing the posterior surface, normally the dissection will be much easier than the anterior or the anterior surface. Now he is trying to search for that, he could not able to see the plane only. Not to become panic at all, you can turn the dissector with a shorter end, try to scratch underneath the cap, then this lenticule open, then you can go with the forceps or you can dissect in between, try to hold the lenticule, be cool, be calm, try to do something sort of a reverse rhexis, go towards the 6 o'clock, try to pull the lenticule out, in the end you will come up with a very good result. So how to avoid it? Identifying the right plane during the dissection is the key. In summary, understanding the finer details of the smile procedure is key to make your patient smile. Thank you one and all.
That was quick and nice, Dr. Kudlu. Very nicely covered so many things and nice pearls. Thank you so much. Any questions from the audience? Anything that you would like to ask? Because I think he has to leave after this.
I have seen almost all the complication in smile. So anything can be managed. The only thing is patient before, if it does the good treatment, then your most of the job is over. Suction loss and dark spots at the incision. These are the two bad complication. It is very difficult to manage. I think all other complication can be managed.
Absolutely. Thank you so much. And I think we have a very interesting round starting now. where we will have presenters who will have only 3 minutes exactly to present, and they should not exceed that time, and followed by discussion. So, yes, exactly 3 minutes, and I'll ask the AV team to please mark 3 minutes. And we will have 8 presenters. We'll be starting with Dr. Pooja Mehta. If she's here, I don't know, I can't see her here. Is Dr. Pooja Mehta here? Dr. Tushar Grover then. Yeah. So this is my challenging cases. So I'll also invite Dr. Kumar. He's actually the co-chairman, and I just noticed.
I've been calling Dr. Kumar since beginning.
Forty seconds is more than enough. 30, 40 seconds. Yeah.
Tushar. So very good afternoon, and thank you for having me. So the case that I'll be presenting is called shooting in the dark. So this was somebody who's undergone LASIK surgery in the past. This is a 35-year-old lady, and the challenge now is the IOL power calculation. So she has a cataract now, and we have to plan surgery for her. Now, when the optical biometer here refused to give any measurements, from the axial length that you get from the ultrasound, you can see this is a high myope. And what is really surprising here is just see how flat the cornea is. So you see keratometry K-mean values of about 25, 26. When you look at the EKR map again, you can see in some of the zones values as low as 21, 22 diopters of keratometry. Now, I went ahead with trying to calculate the IOL power with the ACRS online calculator because that's what I usually use. But the calculator refuses to accept these values, and it goes and tells you to check the values instead. So the lowest values, which I realized on this occasion that the ACRS calculator accepts, is 31 diopters. And this is the IOL power that you get with that. So there is really no direct way to get the IOL power here. So all I did though was, which I could do, was do a bit of a trial and error, see how the IOL power is changing as you move from 31 to 32 to 33, and then try and extrapolate it. And it is a lot of guesswork. It could have been wrong. And so I went ahead with the IOL power of about 21 diopters in this case. We did have some residual hyperopia, so we fell a little short. The other eye, I chose to go with 23 diopters because I wanted to get closer to the target. We had slightly less residual error here and almost hit the target. The patient was happy because we had counseled the patient quite well, but really this could have gone anyway, and I could have been wrong as well. So, which is why I would like to ask the panelists, what would you do, and is there a better way to manage this?
Can you go back to the first slide where, why did you not manage to get any readings on the optical? I mean, other than, what did you manage to get on the optical? Like
It didn't really give much because I think it is because of how flat the cornea is.
So if it's flatter than 30, sometimes the keratometry won't come at all.
Yeah.
And if it's, but the axial length you managed to get, right? Or that also was
The
not
axial
possible?
length also the optical biometer was not getting, so we had to get it on the ultrasound.
Okay, so quite a tough this thing. So I think we have a full panel, and we'll ask our panelists if anybody would like to suggest. So you eventually used the ASRS calculator with, what all did you put on it? I was actually caught with Dr. Kudlu telling me something.
Yeah.
Because we do use the EKR 65 values and they work well on that. Was it not accepting it?
Yeah. So as you can see, I use the Pentacam EKR map values onto the SCRS calculator. The AC depth is something that I had. None of the other measurements were there. And so this is obviously not something that I got. Then
So
I just
don't see
entered.
the Pentacam input, not here, on the ASCRS.
Yeah, so on the ACRS, I had to basically enter 31 diopters. And this is what I got. So, and then I saw how these values were changing as I went higher above 31. Because if you go below 31, the calculator doesn't give you anything. So, and then I just had to extrapolate it and assume that it might, with a reduction in the K values, this is what I would get, and that's how I went for it. But it was definitely not an exact measurement, it was more of an assumption, and it was a risk. So the other option was to leave the patient aphakic and do a secondary, I mean, do an IOL later on.
I mean, it's all fantastic what you have done, but I just wanted to know, did you use only one instrument to measure it, or did you try
We
to
used
do
to.
it?
So we have one lens star at one of the centers. We didn't get a measurement with that, neither did we with the IOL Master.
Okay,
The IOL
so
Master
you've
we have is the
done
slightly
it by
older
two.
one.
Despite two, you got no, I mean,
No.
that means whatever readings you were getting are absolutely right. Then I think we'll just follow what you have done.
So Tushar, I've been in this situation before, and if somebody else has a good answer here. Yes, yes, Rajiv. But what K readings will you feed? Because if it's flatter than 30, you know, and you're not getting a measurement at all, so. Pentacam, yes. In fact, that's exactly true.
Okay.
And you wanted to test. And then you would use the shamas? Okay. Sure. It works well, yes.
Okay.
Yeah.
But does the Shama's formula accept the K readings below 30?
No, that's the
Yeah,
That's
so
the
that
challenge
also would
here.
not
Yeah,
accept
that's
it.
the challenge. here.
Because
I have
think
a
if-
question.
Yeah.
Would you like just go ahead and put a lens there and then do a piggyback for a residual? Or
You could, but then you don't want to do a piggyback, right? I mean, that should be your last option.
One option
just-
is to use the Hoffer-Salvini spreadsheet. So there are multiple K readings which you can input on that and multiple formula. So at least you will know what are the outliers and how close. So various formulas, Shama's is just one of them. There are other Barrett's included. So you could enter all your data, whatever K reading you've got on your autorefractometer and your Excel link by the ultrasound, and then go in with different formulas. So you'll know what are the outliers and what are the closest readings. So that way probably you could have tried that.
But then if any of the formulas were taking these values, wouldn't the ACRS also have
So
calculated
Tushar,
it by
I'm
some
still
formula?
intrigued because your sheet does not show pentacam inputs. You're putting it in the topography inputs where it will not take it, okay? Can you see your maps? I mean, you don't have the pentacam inputs available anyway.
So-
and frankly, I have done
Yeah.
post RKIs where the Ks can be from pentacam, can be like 23, 24. And we have managed to go through the ACRS calculator using the OCT and the pentacam inputs, and we've got measurements.
So
and we've
where
got
do, what
results.
values do you feed, sir?
So,
then?
so there is a space for putting pentacam values. I'm
Yeah,
wondering
the
why it's not
apex
showing
4
up.
mm zone. So the routine way that I have calculated and which has worked very well for me, and it's something that we use during fellowship as well, is to use these ring values, and that corresponds quite well with the pentacam EKR map. But yes, I think what you are doing is probably the way to go in this case, because I haven't done that.
See, the pentacam thing seems vacant on the
Yeah.
on the extreme right.
Yeah.
So that will take what you get from the EKR 65 and will give you an output for the pentacam as well. And if you
Okay.
use the Avanti OCT and you can put in those OCT at the bottom, OCT RT view, that also helps. So we managed to
Okay.
get from those two things for me. I mean,
Okay.
if you have available those two things.
Okay, I'll try that
So,
out.
but pentacam definitely for us has worked the best so far.
Yeah.
Yes. Sorry? Yes, you can. I mean, in the past, that's what used to hold up
Yeah.
hold the best. Yes.
I had a similar case, but I had a case in which there was a post-RK, post-LASIK. So, in fact, the LASIK was done twice. So, he was blessed.
I had a similar one. Yeah, 22 or 23
I was
case.
getting an
Yeah.
IOL power which was between 23 to 26. I was getting from different. So, I did the intraoperative. So, I finished
Yes, sir.
and as a first case. I did other cases.
Yeah.
I didn't sit outside. Then I went outside and did the autoref. And then bang on it came. But what you have to do is I multiplied it by 1.9, whatever refraction
Okay.
you are going to get. Because there is again there are different papers which say, some papers say 1.6, some papers say 2. So I multiplied with 1.9 and I got it.
That worked well.
So
I think
have
that's
four such eyes
very
up till
useful.
now.
Okay. And there have been cases where I find a discrepancy between the pentacam EKR map and the optical biometer, and I've usually found the pentacam EKR map has given me
but
very
only
good
for
results.
such eyes. If you tend
Yeah.
to use it for
No, you can't use it
virgin
for
eyes, then
it.
you'll go
True,
horribly wrong
true,
as well.
true,
So that's a
true.
catch. So thanks a lot,
Thank you,
Tushar.
sir.
I think we'll quickly go on. Dr. Keda Lal, and she's going to present her case.
A very good afternoon to everyone. Before I begin, I would like to thank the IOS for inviting me for this session. As important it is to know how to implant the ICL, I think it's also important to explant the ICL, and we need to know what are the clinical case scenarios where we need to explant the ICL. So that's what my talk is going to be about. I'm going to just show a video where I had to explant the ICL in these two cases. So this is my first case. This is a 26-year-old female patient who has undergone ICL surgery elsewhere about 5 months ago. As we can see that the ICL is flipped upside down. The vault is very low and it is touching the lens. So she has a cataract. Her intraocular pressure when she presented to us was 36 millimeters of mercury. The operating surgeon here has attempted multiple YAG PIs, but still the intraocular pressure remained to be 36 millimeters of mercury. So what we planned to do here was to explant the ICL. We are injecting some viscoelastic to protect the cornea, and then going ahead with our main incision. I decided to enlarge just a little bit so that it's easier for me to explant this ICL and then remove it from the sulcus, use forceps, and then go ahead and explant it. So it was fairly easy in this case. Her intraocular pressure remained high even after explanting the ICL, and she anyways had cataract. So she subsequently underwent trabeculectomy and phacoemulsification with the PCIOL. Now, my second patient here is a patient who has undergone ICL surgery 10 years ago. Then after that, he suffered a shuttlecock trauma, and this is what happened. He has now corneal decompensation, a fixed dilated pupil, an ICL in place, and he has a cataract. So the first thing we did here was to do an anterior segment OCT to see the corneal clarity, the stroma. And then the axial length here actually was 31. Again, this is a manual entry. The IOL power plan was +2 diopters in this patient. He's a high myope. I had a little bit of difficulty in getting this lens out. It seemed to be a little adherent, much more difficult than the first case where the ICL had been implanted recently. Finally, with a combination of different forceps, I could manage to get it out the eye. And we are going ahead with the cataract surgery now. So as we know that the capsule can be a little fibrotic and might be a little tricky to deal with these cataracts post ICL. The lens here is very, very soft, so I just hydroprolapsed it, and then I'm going ahead with basically just using vacuum of 400 millimeters of mercury, hardly any energy used here, and then we decided to implant the IOL, and now we decided to go ahead with pupilloplasty because he has this fixed dilated pupil, so I'm just trying to tug on the iris a little bit so that it's easy for us to pass these sutures to do a pupilloplasty for him. Still, we could not get a very nice round pupil. And he is now subsequently was planned for a DSEC surgery at a later date. I decided to do it as a two-step procedure rather than combining DSEC at this stage. And this is the end of it. We placed a bandage contact lens in the eye. Thank you.
So, if the lens was flipped, why do you think there was chronic raised intraocular pressure even after you explanted the lens?
Yeah, so I think she said that the surgery had been done 5 months ago, but probably the iris got stretched because it was in that position, although it should probably take longer, but even in 5 months, because the lens, the ICL was upside down and it had been pushing the iris up. So it was basically like developing a secondary angle closure glaucoma. And so she, the angles had become very, very narrow. So that is the reason why I think the IOP we were also a little skeptical that, okay, the cataract is there, but IOP should have been controlled if it was just 5 months post ICL. But that just goes ahead to tell us that how important it is that we ensure that we have put the ICL in the correct position. And as a surgeon, if you have flipped it and you have put it the wrong way, you need to really explant it and put it in the right direction. So that is the reason why, even in spite of the operating surgeon had done multiple YAG PIs but not explanted the ICL, but still the pressure remained to be high even after the explant.
Sir, I have a question. Yeah, go ahead. Yeah, please.
I have a few queries. Number one is that, of course, you have not done the multiple PIs. I mean, like, PI, why is it done? That's the first query of mine, but you can't answer it because somebody else has done it. Second is that a gonioscopy would, I think, have given you a lot of answers. And a preoperative, and I know that in our center, guys just will not do an ICL without getting a gonioscopy done. So again, that's not your this thing.
Yes.
But when the person came back, maybe that would have helped you uncover a lot of things. Second is, why did you do a trabeculectomy? Were medicines not effective enough?
Yes, so we waited for, so first thing is YAC PI, if it was my patient, first of all, I would recognize it on table if I flipped the ICL and remove it. And secondly, if this, God forbid happens to me, I would not do YAC PIs for her. I don't think that's the way to go. You need to explant this ICL as early as possible. That is the way to go. That's what the operating surgeon had done. She had just come to me for a second opinion. And the second question was that the intraocular pressure was not controlled. So this patient had to be counseled a lot. So that's the reason why we waited for a month. And she had only been planned for cataract surgery later on. That too we had to plan in a second sitting because she was quite taken aback with the fact that she has developed cataract post-ICL. We waited for a month, even on multiple maximum medication, her intraocular pressure consistently was above 30 millimeters of mercury. That's the reason why we took her for a combined surgery.
I have reservations on this. I'm sorry about that, but I have reservations because I know what a trap does and how difficult a trap is. And to manage a trap, a young patient, I would have definitely wanted to. You see, you can't give 1 month medicines and expect that the pressures will be controlled. No, they won't. There's been so much of inflammation in the eye. First, you have to control that. But look, you have managed the case fabulously. If the case has been managed, patient is comfortable, it's all fine. But yes, I wouldn't have done it that way. That's everyone has his own point of view, so it's okay.
Ma'am, even if the pressure continued to be even apart, in spite of Diamox maximum medication, if it continues to be above 30, you would just do a cataract surgery?
I would have waited. See, the optic nerve doesn't go zoomp. It takes time. It takes time. And it's a young patient. And so if you give it, and that too, you can't take the eye and just load up with medicines. You can't. Just give that eye time to settle down. Believe you me, so many eyes just settle down. Just give it time. And especially just imagine, first of all, the PIs. That itself would have taken out so much of pigmentation. The trabecular meshwork must have got absolutely blocked. Again, after that, you've done fantastic surgery, but surgery itself has released so many prostaglandins. So again, on the trabecular meshwork, which has been bashed up, now you have done another. Obviously, that eye is going to say, yeah, hang on, wait, I need to settle. So it's just that. So you've done a great job, but I would have done it a little in a different way. I would have waited.
Thank you for the input.
Maybe it's my grey hair, that's it.
That's where experience comes in, I think, and as young surgeons, we tend to kind of jump into.
That depends on how the patient is improving. You can't say that I'm going to wait for this time and I'm going to wait for that time. You monitor the patient very closely. Check the pressures regularly. Check whether the inflammation is going down. Would have definitely treated with a lot of anti-inflammatory agents. Keep on checking back. If the patient's eye is comfortable, only then I would have taken up the patient for surgery. And as I said, as Dr. Lal has said, I mean, like, it's okay. If you can't manage, then you go for a trap. But I would have waited.
And here I would like to quickly add that, doing like in our center at least, we have a protocol that first post-op day all patients get an OCT and we document their vault anyway. So if you have a flipped ICL for one reason, like even if it's a beginner surgeon who's doing it, you will still pick them up on next day, and even on subsequent visits we do document the vault.
Yes,
for
absolutely, sir.
That picks up if you're going
absolutely.
to miss, just in case you've missed it on table for some reason.
Yes, absolutely.
But thank you so much, and we'll go on to the next case. Dr. Bhagali Ridhima Nitin? She's not here? Okay. Dr. Reshma Ranade? And yes, if an ICL is flipped, I think we don't even need to wait for a day. It should be out the same day. I mean, and if you do it early enough, you could actually get away by putting it back. But if you wait for some time, then cataractus changes will start. Absolutely, yes.
Mistakes do occur, so
yeah,
okay, we'll grant it. It happens. It's all right.
So why can't you immediately see on the slit lamp? You will get the orientation, how the holes are.
No, probably.
On table only you can.
And that surgeon must have attempted multiple PI because of that only.
In the OT, we have kept a slit lamp to see the wall, to see the orientation of the ICL as well as the flaps as well. So
But do you see all ICL patients in the OT itself on the slit lamp? I mean, yes. Actually, while inserting the ICL, if you've got it upside down, you will know it most often.
In ICL, once the haptics are open, that only time you can pull it back. You pull it back that time
And
itself.
if you watch out for the landmarks on the haptics as well, like for the Indian ICLs, it's not difficult. I mean, you will pick it up. So anyway, but you can still do that mistake, and then you have to be alert. Yeah, even in the most experienced hands, it will happen sometimes, and you have to be careful. Right. That happens to everybody, I think. Yeah. Absolutely. So when you use a new lens, you have to be very alert because you will not know the exact things. Chalo, let's go on. Yeah.
Good afternoon, everyone. I'm here to present a challenging case. So this was a 24-year-old doctor with perfectly normal preoperative topography and normal indices. When we came to the case history, she had a past history of dust and pollen allergy, and as well as she was on nutritional supplements for deficiencies. There was no significant systemic illness. She underwent an uneventful smile surgery with an unremarkable early postoperative recovery as well. However, she presented 5 years post-surgery with ectasia, so what could have possibly gone wrong? Could this have been predicted? Could this have been prevented? What could have been the contributory factors? So does inflammation play a role over here? So recent literature has shown the presence of increased corneal dendritic cells and altered tear cytokines to suggest an inflammatory response in PLE. So this was what her confocal looked like, wherein there was increased dendritic cells, which suggested an undergoing inflammatory response. But was there also another hidden clue on the confocal? Yeah, so these are the healthy corneal nerves post-smile surgery, and you should see in the two pictures lower down, you see poor nerve regeneration with increased dendritic cells in the post-smile ectasia. Is there also another way to assess the inflammatory response? So what could have possibly done was her tear film levels could have been assessed prior to the surgery, but we anyways did it post-surgery when she presented to us. So tear collection was done using Schirmer strips, and then using our patent buffer and the customized biomarker cartridge, we did an ELISA 90-minute assay, and we found that her MMP9 levels were elevated along with increased pro-inflammatory interleukins in the tear fluid. So all this suggests an undergoing inflammatory response. And is there any other factor which is not discernible on conventional imaging? So this is where PSOCT comes in, which is polarization sensitive OCT, which indirectly maps the collagen fibril orientation. So this is a reference image of a normal eye wherein you see densely packed, the more amount of blue shows you densely packed collagen fibrils located centrally, while the picture on your right, it shows you sparse distribution of the collagen fibrils or a loss of checkered arrangement suggestive of ectatic eye. So could genetic predisposition also contribute to the ectasia? So epithelium was collected from the area of ectasia, and a qPCR analysis was done. And we found reduced levels of LOX, which indicates a predisposition of the healthy eye to develop ectasia. So this has been our previous published work, wherein we found that bilaterally asymmetrical corneal ectasia following smile with asymmetrically reduced corneal stromal molecular markers. So post-smile ectasia with a seemingly normal preoperative topography, what are we possibly missing? So number one is factors which suggest an inflammation. So a history of eye rubbing is important. Elevated tear cytokines, increased dendritic cells on the confocal. Of course, poor nerve regeneration, loss of checkered arrangement of collagen on the PSOCT, reduced expression of LOX contributing to corneal strength and integrity, and other contributory factors could have been increased intraocular pressure or poor wound modulation. So what could have been done differently, or if we could have possibly gone back in time? So counseling for eye rubbing, blood levels of vitamin D and Ig should have been done, targeted levels for biomarkers based on our kit, and increased LOC expression due to inflammation control. So trehalose we have known that trehalose augments autophagy and it reduces the inflammation in the corneal cells. This is a normal reference image of the PSOCT, and you can see the cornea, how the collagen arrangement looks like pre-trehalose and post-trehalose. So how does one avoid potential cases of post-smile ectasia? So a good preoperative control of inflammation based on your clinical history, ocular surface, tear biomarker levels, confocals, and an analysis of the genetic markers. You need to optimize the structural integrity, informed choice of surgery, and post-operative monitoring and control. Thank you for your kind attention.
So how did you manage this case?
So, sir, her ablation, if we could have planned a TPRK for her, the ablation.
Whatever has been done.
We did a trek with a KXL, sir, for her because it was a centered cone, and trek allows you to ablate 20 microns of the stroma, which would have been ideal because it was
Followed by cross-linking again.
Yes, sir. Followed by cross-linking. Yes, ma'am. Yes, ma'am.
I don't think so.
That's why I wanted to ask, is everybody using trialos post-operatively? Because
I'm basically a glaucoma surgeon and I do a lot of work in ocular surface as well as cataracts. And they all came along and how the dealers say that, trialos is fantastic. And so we say, okay, let's try it. And I found that, patients say, no, it doesn't work. So when patients say, no, it doesn't work, then you say, okay, take a back seat because it's expensive. So you have to think twice before. That's why I want to know from the panel. Okay, how do you find trialos?
So, ma'am, Trehalose is actually not just a lubricating drop. It's a sodium hyaluronate based drop, and in that they've added mannose-6-phosphate. It acts as an autophagy inducer. So, in keratoconic eyes or in any post-LASIK ectasia or such inflammatory eyes, your MMP9 levels are extremely higher, and the eyes are under a tremendous oxidative stress. So when you give Trehalose for 4 times in a day for 6 months at least, we have seen a lot of patients, not only they stay stable, but they flatten, actually without doing a cross-linking. So the idea here is that it's not just an artificial tear or a lubricating drop, but we do explain to all our patients that this we are not giving as a treatment for your ocular surface or dry eye. We are giving this because it has an evidence that it can keep your eye stable, especially when you have keratoconus or a post-LASIK eye.
These are only 2 conditions you talked about. But what about inflammation, what you're having in cases of ocular surface diseases? Most of us know that you have got, that's why your MMPs have come up. So then what about them?
So in ocular surface conditions, ma'am, it's not just the MMP9 which comes up. There are many other markers which come up. But at this, so we are working, as she suggested, on a kit which will have multiple markers. But it will take another 1 or 2 years for it to come to clinics and for the clinicians to start accepting it. But at this point of time, you do not have it. So Trehalose alone is not the answer, I agree. In ocular surface conditions, you do have to give other drops as well.
Yes, I agree. That's exactly. That means you need something else in the dry eyes which you are getting for whatever reasons, because we know that there's a large amount of inflammation taking place in dry eyes for whatever reasons.
See, most of these patients, my simple observation is you'll end up in such cases where you have ectasia. You don't want to wait for an attempt dose Trehalose or any anti-inflammatory substance for that matter, although you notice difference after 6 months as you claim. But the thing is, would you like to wait and do the same treatment in these kind of patients? Where, then why attempt TREC and do cross-linking in those patients immediately?
So this is a post-smile ectasia eye. This patient definitely requires a cross-linking. There is no question to it. But as she is an ophthalmologist. Actually, I'm not sure whether we mentioned, but she herself is an ophthalmologist, and she was absolutely fine 6 months back, and she's developed ectasia within 6 months. And
how long post-op is she now? Like
5 years. So within 6 months, if she has developed ectasia and in such advanced ectasia, it means there is something going under, and that is the sign of inflammation. No eye rubbing, but yes, her OSDI score was 72, and that is why we kept her first on Trehalose to reduce the inflammation. Otherwise, if we do a surgery, she can land up in excessive scarring or infiltrates. So just to avoid it, we wanted to reduce the inflammation. That's why we give Trehalose and then took her up for surgery. Ma'am, cyclosporin can also be given in this case, but she was, I think, not in the favor of using cyclosporin. No, ma'am. It's extremely surface irritant, and the effect what you get with Trehalose alone is much better, and patient satisfaction is much better there compared to tacrolimus.
any patient of keratoconus, Trehalose is your normal regime?
We give post-operatively all our patients Trehalose because the epithelial remodeling is much, much better in keratoconic eyes. So all our keratoconic patients, when they undergo cross-linking, whatsoever cross-linking, we do give them Trehalose.
Even without cross-linking?
Without cross-linking also. If it's grade 2 or higher. If it's grade 1 or FFKC, we do not give.
I give cyclosporine plus trehalose. I think it
We give both, but it's not mandatory. But as a lubricant, we do not give any normal lubricant. Lubricant is in the form of trehalose.
So any pomifluste keratoconus, are you recommending trehalose?
It's up to you, sir. If the patients have complaints of ocular surface inflammation or dry eye, you can give.
For prevention of deterioration?
It's an overkill from first keratoconus. But if panelists can decide, correct me if I'm wrong.
I think, unless you've actually documented the, inflammatory markers and everything in detail, and I mean, in your kind of case that you've said, because otherwise, as she said, it would be an overkill, huh?
It's not possible for us to...
Exactly. So that's why, that's exactly what in fact, I was going to ask you, since you said that your recommendation was that in all SMILE patients do a workup for all the markers and everything, and 99% of us won't be able to do that. So in your setting, it does work. But for us, when we talk in the meetings, we have to talk about what works for most people. And
I think,
for that,
yeah.
I think we have all the set parameters. So it's good to know, because, then we can people can plan what else needs to be done in the future, I think. So in that sense, it's very nice. Thanks.
Sir, I have a question. Yeah. Since this case had an ectasia which came up in 6 months' time and was stable for 5 years post-surgery, you also mentioned that she was on dietary supplements for some deficiencies. So whether we need to look beyond the eye, because there was a high inflammatory response in the eye, so whether it was any other systemic deficiencies or whether there was any hormonal change, because that could be one contributing factor in an eye which is stable for 5 years, and why will the ectasia come up in 6 months if it is just an ocular surface inflammation? So whether there are any systemic factors, it could be B12, it could be B9, it could be a vitamin D3 deficiency which needs to be worked up in this patient.
Absolutely right, ma'am. I agree to that. But a detailed history for her systemic illness was also taken up, and she did, before we planned the surgery, she did get a physician checkup done as well.
So I think important point highlighted there, but I think we are short of time, so we'll have to move on. So we'll invite our next presenter, Dr. Prajakta. Yeah. Dr. Prajakta Partikar. So 3 minutes again. Yeah.
So good afternoon, everyone. I would like to thank AIOS for giving me opportunity today. So I have 2 cases here, which is of suspicious topographies, which I felt were challenging, and I would like to take opinion from the seniors here. So this was case 1, 29-year-old female. This was a BCVA with predominantly cylinder. She wanted freedom from glasses. So this was a right eye topography. Here you can see the anterior tangential curvature. There was some amount of inferior steepening. There was no significant posterior elevation. It was a thin cornea. The indices showed thickness of 467, 4.47 cylinder. The machine labeled it as borderline. The superior inferior asymmetry was plus 0.08, plus 0.82, which shows there is inferior steepening. And the aqueous depth was 2.66, which was below the cutoff for phakic IOLs. Similarly, the indices here, others were everything was normal limit, only the curvature asymmetry was there, and the thickness was lower. Similarly, in the left eye, the anterior curvature showed a superior steepening. Again, no posterior elevation, again a thin cornea. Similarly, all the other parameters were same. Aqueous depth was lower, and this was labeled as normal. Here, the superior inferior symmetry was minus 0.26, which shows a superior steepening. So I'll come to the points of discuss later. So this was the second case, 22-year-old female, high myope with some amount of cylinder, came for refractive evaluation. This was a topography. All other parameters are normal, only the posterior elevation showed a isolated island of elevation. The scan was totally depicted as normal by the machine. The keratoconus summary also showed that persistent posterior elevation. She had a pentacam report done elsewhere, which also repeated the posterior elevation, which was also seen on the BAD map. But the BAD D value was normal and it was not seen in the difference map. Similar picture in the left eye, no significant posterior elevation, thick cornea, but similar mirror image, the posterior elevation was seen again on the posterior elevation map. Thickness was normal, aqueous depth normal, the scan was also normal. Same repeated on the left eye, mirror image, posterior elevation. Similarly seen on the pentacam also. But again, the bad D value was normal, and the difference map also did not show any significant abnormality. So I would like to discuss these cases. I'll go back to the first case.
What was the refractive error for the second case?
It was a high myope. I'll just come minus 6 or 7. I'll just come. Minus 7.25, 6.75.
What is white to white?
Right, I was 11.84 and left eye 12.12. So can we ignore the posterior elevation? Can we go ahead? Should we observe?
It's not a posterior elevation actually. It's just
Yeah, it's just a, yeah, that's what. So can we go ahead still? Okay.
for the first case, I think
It's a high cylinder.
high cylinder, you can't go for PR guide.
Yeah, and phakic IL also is ruled out because it is 2.66.
Frankly, I am not seeing that topography also normal.
So case one, leave it.
What is the refractive error here?
Case 1, it's minus 6 and minus 7 cylinder. Predominantly cylinder, there was no sphere.
An ACD of 2.6.
But there's no posterior elevation as such in the map, and even machine says it's a normal scan, though it's a thin cornea.
So, too many things are standing out. The thin cornea, the high astigmatism, and I mean, even though the maps may look absolutely fine, still, I mean, the very fact that your corneal thickness is thin. I mean, I'm just saying that even if your map was fine and everything was perfect with such a thin cornea, I mean, and then correcting.
But in thin corneas, wouldn't the parameters be, they should not be reliable, right? Like,
no, not
generally.
So thin cornea by itself is one of the indices which it qualifies an eye to be put on watch. I mean, put on the card. So anyway, I mean, the first one is clear. Second one, I think you have those
isolated elevation patches.
Yes. They can be artifactual sometimes, and
but it's same in the pentacam also. It's repeated.
Exactly.
Any
I mean,
subtle scarring or anything?
Yeah, so but
in that
she's,
area?
it's symmetrical in both eyes.
Yeah.
That's a funny thing because sometimes you've seen in one and yes, you may have scars.
And repeated on the pentacam also. And I have acquired the scans like 2-3 times.
What about epithelium maps in the second patient?
No,
you don't have access. That would sometimes. I know it's posterior, but I mean it would be worthwhile seeing what's on the surface as well sometimes in that area. And but again, it's a dilemma. So I don't know if anybody else has anything to add. I don't. Yeah, when in doubt, maybe ICL is
second was ICL. Yeah.
Sure.
Relative pachymetry at that zone where there is an elevation would help actually to find
it's
out
a thick
what
cornea.
where.
It's 600 in that.
But there was no
the relative
corresponding
pachymetry. I'm not talking
thinning
about
also.
the total the relative pachymetry. Individual map, relative pachymetry at that zone. That might give some clue.
That might give us some more information.
No, it's on a temporal side.
It's in the periphery.
There's no corresponding thinning also.
So would you do a smile extra for this patient?
I probably would, yeah. Yeah, whenever in doubt, if you're doing a smile, you can switch to smile extra.
No, smile extra or phakic?
So, phakic would probably be a wise choice here because smile extra still remains in a gray zone. I mean, for the sake of discussion, we could do that, but if you have to give a message to the audience, I think it would be ICL. Yeah. So I think, thank you so much. We'll go on. We have Dr. Urvicha Chaudhary. She's not there.
Yeah, we can't.
And then Dr. Mohak Shah. And then we have two very interesting talks after that, so we'll restrict ourselves to 3 minutes for the presentation. We have two talks, one on return of investment in LASIK, which is really an important topic today, and then marketing and counseling. So I think for all of us who are in refractive surgery, these two talks will be useful.
First of all, I'd like to thank Dr. Gaurav sir, Dr. Kudlu sir, Dr. Amrish Darak sir for giving me this opportunity. Okay, so I think all of us are doing the surface ablation, I guess. Mirror display. Okay, so I had a 24-year-old young patient who came back to me in 2016. He had a modest refractive error of 3.5 spherical with zero point 0.5 SIL in the right eye, and in the left eye it was -3 sphere with 0.75 SIL with absolutely normal all other parameters. Only thing the catching point was he had a family history of keratoconus in the sibling. And patient wanted to join the army or the police. He wanted the absolutely 6x6 vision, and he was so much determined that he wanted to undergo a refractive procedure. So we waited for around 1 year for this patient, and after the proper counseling, what we thought, as he has a family history of keratoconus and his job requirements are there for the 6x6 vision, one should go ahead with the surface ablation. So we decided to go ahead with the two-step trans-PRK procedure, and with this performed on the Zeiss MEL 90. As we all know, in the Zeiss platform, we have to go first into the PTK mode. We have to ablate around 50 to 50 microns. Nowadays, we are doing the epithelial mapping and doing it, but at that time we didn't have it. So what we did, we removed around 52 microns of the epithelium. Then we just cool it down, because as we know, the temperature ranges up to around 38 degrees, which causes a lot of significant heat if you don't give enough time for the cooling. So we did this cooling with this wet Merosil sponge. Then we'd go into the PRK mode, treated the patient as per the refraction. And as we all know, we have to apply the mitomycin C to prevent the haze. So we use the mitomycin C, it was 0.02%, and we applied as a 1 diopter, 10-second exposure. Then we washed it with the 20 to 30 cc of the chilled BSS. We also used the ketorolac soak BCL as well. So we did everything perfect what we could do with any of the surface ablation case. After 2 weeks, the patient was doing fairly well. These are my records. Patient was reading 6.6. Refraction, you would say, it's absolutely almost emmetropic. The patient was then lost for the follow-up, and patient came back to us after 11 months when he had a break from the army. And suddenly what we saw, there was a significant central reticular haze. Patient vision was 6/36, and the patient's refractive error came of around -6.25 sphere with 0.75 cylinder in the right eye, and almost -6 with -0.5 in the left eye. So at this stage, I was wondering what I could do next. I think the first thing which comes into our mind is to treat the patient medically with the potent steroid cyclosporine, as Pooja also mentioned, with the trehalose and the tacrolimus as well. So I started the patient on everything. And this is how this haze looked on the pentacam. You can clearly see over here. This is significant haze, and there was epithelial hyperplasia as well. I don't have the epithelial map here, but it was around 80 microns of the epithelium hyperplasia. Similar thing with the left eye, and this is how it looked on the topography. You can see this is a steepening, inferior steepening is there, which corresponds to that reticular haze in that area. Same thing was observed in the left eye. So again, I was slightly a bit skeptical, so we started the patient all this treatment, but unfortunately, patient developed the steroid-induced glaucoma only after the 1 month of usage. We started him on the prednisolone acetate because as the haze was quite significant. Then we gradually lowered the patient to the lotepredilol. We started for the 3 months. We gave the cyclosporine, we gave trehalose, along with anti-glaucoma medication, but still there was absolutely no improvement. Haze remained the same. So the next thing which came to mind, what I could do next, whether I should go for the PTK, first clear out the epithelial hyperplasia, then treat the patient's refractive error. The patient was quite skeptical. He was absolutely anxious, nervous. We didn't know what to do. So I just gave the patient the glasses, and this is what I gave. And the patient was asked to follow up for every 3 months because I was slightly concerned whether the patient can develop the ectasia or no, seeing that inferior steepening and all. And we waited for almost, I would say, 5 years and tried to explain him to undergo for this PTK followed by the PRK, but he was absolutely not ready. So next question is what I can do for this patient. And this is what the readings came. Just recently I have operated this patient. 21st Jan readings are here. These are the March readings. So absolutely 2 similar readings I got. And then I decided to go ahead with the other procedure. And this is what the pentacam looked like. ACD 2.99. As you can see, this inferior steepening is there, which is absolutely stable. Absolutely nothing. All other parameters are normal. In the Bellin D is perfect. Just 30 seconds more. Similar thing was observed in the left eye. It remained absolutely stable like it was initially 6 years ago. Again, ACD of 2.93. So my question is, what would you do? So that is what I did. I wanted to play absolutely safe. So I went ahead with the ICL implantation. As you can see, it had a fairly good ACD, 2.92 from the endothelium. Another eye, again the same one. And this is how the patient is looking right now. Here you can see there is a slightly haze is there, central haze, reticular haze. But as far patient is doing quite good. So patient is reading 6/6, vault is pretty good, absolutely stable, everything is okay. So my question is, can any of the panelists have done differently from this? Because I wanted to play absolutely safe. The patient also wanted to play absolutely safe. And I think this was a win-win situation for all of us. Thank you.
What was the refractive error to begin with? I missed that first.
Begin was, sir, only 3.5 and 3. So I ended up having actually the double of that. So another reason I was quite skeptical of doing the re-PRK was that I might end up with the more significant haze. And
when you treated, I mean, when the patient came back, I noticed that patient was 636 and
Yes.
not improving or improving?
No, it was improving to 6 by 6 partial with the correction.
Because typically when you have haze of this kind, even the BCVA goes down as well.
Yes.
So that's one thing. And here actually epithelial maps would have been useful to see, but then, still nothing would account for 6 diopters of
Exactly,
myopia.
sir. So epithelial hyperplasia was there. It was 80-85 microns.
Okay.
It was not. I know. Yes. We did take the history. We also inquired whether he has a past taken disotetinone and all, but it was not there. So it was a quite unique case which I faced for the first time. That almost patient reflex was -3 and I ended up almost double. So that's the reason I was quite skeptical for doing the PTK as well. Yeah. Wrong. Exactly. Yes.
Makes perfect sense to again do an ablation. Probably
Yeah.
panelists can give the expert comments.
I would differ on that basically. Many a times, see, there are two parts. One is the doctor's job and second is the patient compliance. Many a times what happens in these patients, once they start seeing better, there is a problem with putting up the drops regularly, and particularly when you are doing PRK, you have to warn your patient n number of times to use the treatment for at least 3 months. Tear substitute or whatever. And second thing, means by default, like I don't have all these equipments to map the things, but by default, whenever I am doing, in fact, few LASIK cases also, whenever I am doing, I use this cyclosporine by default in these patients. And another
So
thing
we
I do is
give cyclosporine to all our PRK patients.
My first question is, why did you opt for PRK in these patients?
Patient had a family history of keratoconus in the sibling. That was my first thing. Although the pentacam was normal, absolutely was normal, I didn't want to take any chance. Second thing, he wanted to go in the army and the police one, which requires you to not to have those flap-based procedures. So that was the concern. Sorry?
Was he in army?
Yes, he was in army. So what I think, he was exposed to the more UV light, sunlight, and that caused this haze.
That actually justifies.
And he was lost on the follow-up because his training started. So that is the reason. That was the reason. So, but many of the times we get cases like this. So what could you do? This is the first time I observed this type of thing.
But the second thing is, like Ikra said, keep doing PTK in these patients where you are not sure, very sure of compliance. Even PTK followed by PRK, or simply do PTK, the results are quite good in those.
Should we have used
Yeah.
mitomycin for longer time in this patient?
The second time when you do, we would use it for
For
2
second
minutes.
time, you have to use this
2
for
minutes.
at least 2 minutes. But I was not ready, even the patient was not ready, because I didn't want to treat the patient again with the -6 of, even PTK would have corrected, hyperplasia was there 80 microns, so I think max 2.5 diopter would have treated, still 4 diopter would have been left. So I don't know how the patient would have been after if I go. First time I did use, the normal protocol of using the mitomycin is 1 diopter, 10-second exposure. So I used it for around 40 seconds.
I think it's occupational.
Occupation is the culprit over here.
Add
So
one word
please
to
do that,
this
yes.
because I have put in 34 years in the army. You see, when a patient comes to you, you have to talk about occupation. Now, most of the people who are staying in Bombay or any of the places, they're sticking to one place. We are going all over India, from where it may be Siachen, that guy may be going to, down to the deserts. And these guys, mind you, when they don't go to big hospitals. And our government hospitals and army hospitals, in some tertiary hospitals only we are well equipped. But we are not as well equipped as you people are. We have only certain things. We don't have super specialists in all hospitals. In a small little multi-speciality hospital at 11,400 feet in Leh, we have one eye specialist, one ENT specialist, etc., etc. So if that guy is posted in Leh, he's not going to be able to get that treatment, he may lose his eyes. So my request as a person from the armed forces is, please, do consider that guy.
Yes,
He's
ma'am.
going to
We
get
did
only
also, in
25
fact,
to
we did
30,000
advise.
rupees. And he's going to spend everything on his treatment. I feel very bad. I'm sorry about that. I feel very
we
bad.
did take the occupational history. That's the reason we opted for the PRK, because he wanted to go for the army and police. We knew that he is going to be exposed to this. We also advised him to wear the sunglasses and everything. But still, those people, sometimes patients don't listen.
So, in fact, I think
Exactly,
both of you are right
exactly.
in that. Because problem is that, they come to you seeking a solution. You try
Yeah.
to do your best for them. Problem is that the compliance may not be good, and it's not possible for them to comply. Sometimes they may want to do it, they may not be able to put their steroid drops properly because they are on the, they're out on, they're out patrolling. They cannot wear glasses. In fact, I just tell this to many of them. I tell them, you can get non-colored glasses. They say, no, sorry, we can't even do that. Then I tell them, you wear a cap. Protect yourself. They say, okay. So it may be beyond them to do all these things, and we have to keep that in mind. And you did your best.
Yes.
But what ma'am has highlighted is also so important, that we have to think of all those things that guy may go through. He may be desperate for a surgery, and yet it becomes our responsibility to understand whether he will be able to comply with what we are doing for him. So a low maintenance procedure would anytime be a better procedure than something, So I think you have to kind of judge all these things when you discuss with a patient. I think that's what it boils down to.
Yeah, they are not going to listen.
So I think we'll go on.
No, ma'am. They come to me, I'm now working in a corporate. I tell them, no. Ma'am,
they just sometimes will go to another place which is happy to tell them that, come in, walk in, lie down and do it now, So, and they might get, ma'am, but then, that again is our responsibility, because we are maybe losing that patient to unscrupulous practice, which may, so I think educating them and then maybe doing something for them is more useful than letting them go and get it done somewhere else, and then still it's our responsibility, we let them go into that situation. So, I know, it's very tough. So I think we'll quickly go on, and I'll invite Dr. Amrish Tarak, who has been one of the most experienced refractive surgeons. I've learned a lot from him 20 years back when I started doing refractive surgery. Return of investment in LASIK, and he has a wonderful understanding not only of the practice, not only of the practice of LASIK, also he can actually play with the machines, and he's one of those guys who can, better than the engineers, still play with the machine and set it right if he has to. So he has a comprehensive knowledge, and we'll listen to Dr. Darak come up with two topics, return of investment in LASIK and marketing and counseling.
नहीं है मेरे पास तो अभी ठीक है अभी किसी और को दे दो मैं मंगा लेता हूँ वहाँ से मंगा लेता हूँ इतना टाइम कहाँ है ख़त्म ही Thank you, Dr. Gaurav. And the good part is I don't have my presentation here.
So you're going to talk
so I uploaded. Now probably I'll have to talk extempore.
You can do that, I know that. So absolutely fine.
So, good afternoon, everyone. And I'll be sharing my thought process and my experience about the thing which I am yet to answer and I am yet to understand about it. My refractive career had been a very roller coaster ride. So every time you take a loan, you go bankrupt, you buy a machine, and you again start struggling from the beginning again. So the first question comes to my mind whenever this topic was given, ROI and marketing and everything. So first question arises is, why do you want to go for refractive? Why do you want to buy a machine? There are three possibilities. Either you are a very good cataract surgeon, you are earning a lot, and you want to upgrade your practice. Second thing might be a person like me who is tired of monotony, who doesn't want to do cataract, he is not enjoying his procedure and wants to get over to refractive to understand the thing. And third possibility is you are earning so much that examiner gives you a good amount of depreciation. I am yet to see a fourth possibility. So let us discuss one by one. You are a very good practitioner, you are earning, you are doing premium cataract surgery. Your other fellow practitioners in other city or in your area, they are doing good. They also have refractive. And somewhere it starts pinching your ego. You feel कि अरे वो 30,000, 50,000 वाली cataract करता है, 50 करता है, why not I have that machine if he has. And mind you, I have come across these examples. because I was visiting 16, 18 centers across the country. So without even understanding our need, people used to jump. उन्होंने Z50, Z100 लिया, मैं भी Z100 लूँगा. उन्होंने 500 लिया, मैं भी 500 लूँगा. उन्होंने 500 लिया तो मैं रिफ्रैक्टिव सूट लूँगा. So I feel कि you have to understand what kind of practice you are into, what your demography permits you. Because you are doing 100 cataract surgery a month, but you don't have premium IOL practice, which can actually generate you a good amount of patient for yourself. So I don't think it's an ideal situation to go for refractive equipment. If you are doing 25, 30, see, reverse is true. If you are a good cataract surgeon, putting up a refractive platform will give you more cataract surgery. But mind you, your refractive installment should come from your cataract surgery then. So the area where you practice, the clientele you are catering to, the competition. See, my talk today will be very transparent. So try and understand my feelings. The thing is, any company, say in 2004, 2003, when I bought an equipment, so while selling you the equipment, they'll talk about technology, and the best part they will tell you is you will be the only one having this. So you buy the equipment and you start marketing for them. So I bought Zyoptics, and then I started shouting from the top of the roof, I have Zyoptics, I am providing Zyoptics to everyone. And within 6 months, the next Zyoptics is launched in your nearby area. So any company will create a competition so that it will increase their as well as our business. Now a logical question comes to mind. In refractive, whether you want to market the company or you want to market yourself. Because the moment you talk about technology, the moment you talk about certain things like Contura, Zyoptics, every doctor will shout. But indirectly, try and understand, you are building a brand for the company. You are not building a brand for yourself. It took me almost 10 years to realize that. Because you buy equipment, refractive is a very demanding thing, and you have to be the best. So every 3-4 years, company will come with new platform, and you will keep on taking loans every time. Whether you buy the equipment on deferred payment, you take a loan or anything, but every 5 years you will renew your loan. तो मैं तो refractive को CC बोलता हूँ. So don't market for the company, market for yourself. This is what I feel a lesson learned with lot of hard work. Second thing, if you want to start your practice, I would suggest if you want to start in a group, there are 3 possibilities again. You individual, buy the equipment, enjoy all the privileges, but at the same time, your friends won't send patients to you. Second thing is entering into a group practice where you all contribute for the equipment and start running it. It's actually ease out your burden, but at the same time, you are not owning the title. The third possibility is you set up a neutral center and call your friends, get associated, and start a neutral center concept. So it all starts with neutral center. But in my experience, whatever practices I have come across, group practice doesn't survive. Because it starts with a noble concept and then turns out to be वो महीने के 4 ही लाता है, मैं महीने के 10 ले जाता हूं, and then the dispute starts. So I have come across almost 12 centers like in India where it started. Most of the companies, they will help you. Sir, ये कर लो, ये group form कर लो, ये कर लो. और 12 सेंटर ऐसे हैं कि जहां से वो मशीन 6 महीने साल भर में उठाया गया है फिर से. Because the center didn't do well. Do we really think कि in spite of 30 ophthalmologists coming together, you cannot build a practice of 40 patients a month? Then it's a time to introspect. So, when we discuss about buying a refractive, means I'm sorry, I'm sounding discouraging thing. Dr. Pranay is looking at me constantly. He is starting another venture. So, but my duty is to point out all the negatives before I start talking encouraging words. So, ideal situation is like-minded people coming together and buying the equipment. If you alone want to buy and test the water, I feel better to start your refractive career with a refurbished machine, develop a volume at your end, and then jump into upgradation. Because upgradation is the motive. When being a cataract surgeon, you want to get into refractive practice. Upgradation is the motive where you want to develop, want to have a good name in refractive also. So start your career with refurbished machine and get into upgradation once you achieve the break-even. In refractive career, normally ROI जब calculate करते हैं, ROI हम we talk. So कोई भी business में, a normal business, any company, they talk about ROI, you should have a break-even within 1,000 days. But in refractive, I feel the ROI extends up to 4.5 years. So you have to calculate at your end the economics for 4.5 years, then only you will survive and you will succeed in refractive career. You people won't agree with me, but you are second generation ophthalmologist having refractive at So few things I have learned from Dr. Gaurav. So whenever I used to buy new equipment, I used to call him, discuss the things. And second thing, every company you go will talk about how updated and how they are the best. But if you are starting your refractive career, don't go for the best, go for what suits you. Buying an equipment of 1.5 crore and achieving a break-even is far more easier than buying a super technology and then spending entire your life in marketing it and to have a break-even for 5 crores in 5 years. And the last option, a mad person like me, who has passion. So every 4 years, keep on changing the equipment and doesn't have his own house till date. But you have to be absolutely passionate to have this kind of thing. But ideally, logically, I won't suggest anyone to go for it and do this way. You have to be, don't go for the best. Try what suits you. Try what suits to your practice. Because I won't call myself as a successful refractive practitioner. You are successful when you are able to achieve the ROI as desired for. You are able to achieve a name for yourself, and you are able to achieve a brand of yourself. Then only you will be a successful refractive practitioner. Thank you very much.
Excellent. excellent talk, Dr. Darak, and I think that's experience speaking from there. And yes, all the challenges that he's explained. But there's only one thing which I would like to add here at this point. Something which has come up over the last few years is that you can actually start your refractive surgery career working for an institution which is fully equipped, has almost everything, and you could get a good training, and so that's the only thing which has changed from the time we started working. So there is that option for young surgeons now to join up in a center which already has good refractive surgery equipment available, and you can join and start doing it. And there are good numbers of such places who have invested. So best not to invest into it yourself till you are established as a surgeon and experienced, and then you will be more, and then have a good practice. So I think he's covered up almost everything. This is the only thing which I thought might, ma'am, anything that you would like to add to this? Very words of wisdom. And I think the other thing is that the world of marketing has changed so much in the last few years, as we've all seen. COVID times have changed things. There was print media which used to work very well 15, 20 years back. Now it just doesn't deliver. The digital marketing has taken over, and then improvisations in digital marketing. So you have to not only be a good refractive surgeon today, you could have the best machines, you could have the best hands, and still it is not enough. Sometimes, you need to kind of beat the system as well. So that's the other thing which I would like to point out. Be prepared to, take that as well along with you. Just being a great surgeon and with the best equipment and doing good work is not enough anymore. So, anything that Amrish you want to add to that? There's no end to all that. So thank you so much. We had a great session, and we'll call it off now because we've overshot time. Thank you, ma'am. Thanks, and thanks to all the speakers.